Hello there, my highly esteemed and treasured viewers and listeners, and welcome back to our Pharmacotherapy MCQ series. Welcome to part 10 of the series. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for people working in the healthcare sector. The virtual clinical pharmacy institutes with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high impact pharmacotherapy services. So I would urge you to sit back and spare me a part of your precious time to share some tips with you. So let's move to question number 1. Patient G.A.O. is a 77-year-old lady with a 6-month history of excessive worrying. Now, this problem began when the spouse died suddenly. She is currently taking 100 milligrams of allopurinol orally once a day for her gout attacks. She also takes pravastatin 80 milligrams at night for dyslipidemia, and she was put on 0.25 milligrams of lorazepam when necessary, up to 4 times daily for her anxiety. Now, patient G.A.O. notes that she takes a dose of lorazepam once or twice weekly. Now, the psychiatrist examining her at your clinic diagnoses generalized anxiety disorder, what they call GAD today. In addition to continuing lorazepam, which additional drug would be indicated for our dear patient for her treatment? Would it be buspirone 5 milligrams taken thrice daily orally? Would you add quetiapine 25 milligrams at bedtime? Would you add duloxetine 30 milligrams orally once a day? Or would you give her hydroxyzine 50 milligrams orally at bedtime? I'll give you 10 seconds to make the correct choice. So personally, I would settle for duloxetine, administered at a dose of 30 milligrams orally once a day. Answer A, in my opinion, is not correct. Buspirone is indicated for long-term management of GAD. It is not first-line therapy. The use of SSRIs or SNRIs is appropriate as first-line therapy for long-term GAD, and the SNRI, which is duloxetine in this case, is approved by the FDA for this particular treatment. There is some concern about a possible decrease in effectiveness of buspirone in patients who have utilized benzodiazepines in the past, just like our lady here. So continued PRN use of lorazepam in the patient is considered appropriate until long-term maintenance therapy of GAD takes effect. In my opinion, the antipsychotic in option B is not appropriate. It can be used as an add-on therapy in patients with GAD, especially if, and I'll underline the word if, psychotic symptoms occur with the anxiety symptoms. Now, the use of SSRIs and SNRIs is considered first-line therapy. So, quetiapine would not be my best choice in this case. Answer C is correct because of the explanation I've offered. I would settle for duloxetine, 30 milligrams orally once daily. And answer D is wrong to me. Apart from the above explanations that I've offered, hydroxyzine can be utilized for the physical symptoms experienced by patients with GAD. However, it appears on the Beers criteria for potentially inappropriate medication use in the geriatric population. It would therefore be a poor choice for this particular patient because of the unfavorable risk-benefit profile. So I would not go for option D. I would settle for C. So let's move to the next question, which reads, K.H.R is an 83-year-old patient who recently had cardioembolic stroke. So her medical history, she has AFib, which could have led to the stroke, GAD, and she's hypertensive. On doing medication reconciliation, the only antithrombotic therapy he has been taking prior to the stroke was Warfarin, and the INR from the records he's been keeping a diary was in the therapeutic range only 45% of the time according to the chart review. And from your quick computation, his recent child's FASC score is 5 and his Hasbled score is 2. The multidisciplinary clinical stroke team asks, which of the following is the most appropriate medication for Mr. K.H.R to use as secondary prophylaxis for cardioembolic stroke at this time? Would you settle for Apixaban, Dabigatran, Clopidogrel, or Warfarin? I'll give you 10 seconds to choose the correct drug from that list. So I would settle for Apixaban. Answer A is the correct one because Mr. K.H.R is over the age of 75. He's had difficulty maintaining an INR in the therapeutic range, which guidelines say should be ideally above 65 to 70% of the time. And there is a history of GAD. Answer B, in my opinion, is incorrect. Dabigatran isn't the most appropriate choice due to his history of GAD. And one of the major adverse effects of Dabigatran is GI bleeding. So this patient would be at risk if you put him on Dabigatran. Because he's above 75, there's an increased risk of bleeding with this particular product compared to Warfarin. Now the risk of bleeding is lower with Apixaban than Warfarin, however. So the Apixaban would be superior to Dabigatran and to Warfarin. Now answer C is incorrect in my opinion, however, as well, because Clopidogrel monotherapy is inappropriate for a patient like K.H.R because he has a history of cardioembolic stroke. The current guidelines on antithrombotic therapy in patients with AFib, like this particular one, recommends against the use of antiplatelet monotherapy for cardioembolic stroke prevention. Instead, if you read carefully, they recommend the use of novel oral anticoagulants. And finally, answer D, in my opinion, is incorrect. Warfarin isn't the most appropriate choice because the patient has a difficulty with maintaining his INR in the therapeutic range. So let's move to the next question, which reads, Mr. ZAJ is a 49-year-old HIV-positive man with the following lipid panel. His total cholesterol is 240, LDL is 160, HDL is 25, and triglycerides are at 220. He's currently on boosted darunavir, and he takes emtricitabine co-formulated with tenofovir disoproxil fumarate. Family history is significant for cardiovascular disease. The dad died of a heart attack at a tender age of 48. So, which of the following drug therapies for dyslipidemia should Mr. ZAJ be initiated on at his next clinic visit, if any? Would it be sustained release niacin? Would you settle for a combination of pravastatin and fenofibrate? Would you initiate rosuvastatin at bedtime? Or is it true that anti-dyslipidemic therapy is not indicated or needed by Mr. ZAJ? I'll give you 10 seconds to respond to this question. In my opinion, C is the correct answer. I would put him on rosuvastatin at bedtime. Answer A, in my opinion, is wrong because it is not first-line choice due to the adverse effects, and there is limited data in the HIV-positive population. Answer B appears wrong to me. His triglycerides are well below 50, and 50 is the level above which fenofibrate should be used, so I would not settle for that option. Answer C, in my opinion, is correct. Rosuvastatin is the best choice for this particular patient, especially given his family history. He lost his dad at an age of 48 from a heart attack, and I don't expect a major drug-drug interaction with his ARVs. That would be out of the ordinary. Now, answer D, in my opinion, is incorrect. This therapy is indicated for this patient because from the results, his fasting lipid profile, based on the American College of Cardiology and the American Heart Association guidelines, qualifies him for therapy for dyslipidemia. So let's move to the next question. So this time it's a lady. Madam G.G.K. is a 36-year-old lady newly diagnosed with HIV. After effective and lengthy counseling done at your comprehensive care clinic, she is scheduled to initiate highly active antiretroviral therapy and any recommended opportunistic infection prophylaxis. So on probing, on doing a thorough history, she tells you she's never had any OI. Her pertinent labs include a CD4 count of 50, HIV RNA of 125,000 copies per ml. Her BUN is 14, her serum creatinine is 0.6, and Toxoplasma-specific IgG antibody is positive. Glucose 6-phosphate dehydrogenase is below the lower limit of normal range. So what opportunistic infection prophylaxis is indicated basing on these lab results that I've just read? Is it PJP and MAC? Is it PJP and toxoplasmosis and CMV? Is it toxoplasmosis and MAC? Or is it PJP and toxoplasmosis? I'll give you 10 seconds to choose the correct answer. So D is the correct answer to me. A is incorrect. Based on her CD4 count, which is 50, and her seropositivity for toxoplasmosis, she should receive primary prophylaxis for PJP and for toxoplasmosis. The threshold CD4 count for prophylaxis are usually below 200 for PJP and below 100 for toxo, to which she is seropositive. Now, new guidelines out there don't strongly recommend prophylaxis for MAC with a CD4 of 50, especially if a patient is initiated on highly effective HAART. So answer B is incorrect because primary prophylaxis for CMV is never warranted in patients with HIV. They would rather treat after the first episode. And answer C is incorrect because new guidelines, as I said, do not recommend MAC prophylaxis if a patient is doing well on their medication. So let's move to the next question. From a chart review of a 29-year-old HIV-positive female patient, you note that the CD4 count is 60, and you also note that she has not received any recommended vaccines since she was 18 years of age. So which vaccines should this patient avoid given her low CD4 count of 60? Would it be tetanus, diphtheria, acellular hepatitis, Tdap? Would it be measles, mumps, rubella? Would it be the pneumococcal vaccine? Or would it be influenza injectable vaccine? I'll give you 10 seconds to make a choice. Settle for B. Answer A is wrong. This vaccine should not be avoided because it is an inactivated vaccine which is safe to use, and it would generally be recommended in HIV infected patients. Answer B, in my opinion, is correct. It should be avoided because it is a live attenuated vaccine which carries a risk for contracting active infection when administered to immunocompromised patients whose CD4 counts fall below 200. And answer C and D to me are incorrect. They should not be avoided because they are both inactivated vaccines which are safe to use, and they would generally be recommended in HIV seropositive patients. So let's move to the next question. A 25-year-old HIV positive lady has a CD4 count of 50 and has started HAART. She's also taking Bactrin, sulfamethoxazole, trimethoprim, the DS, the double strength, 1 tablet orally once a day for prophylaxis of toxo and PJP. Given her frequent exposure to cats, a toxoplasma IgG test was ordered and the results turned out positive. God forbid. Would you recommend or initiate additional prophylaxis for toxoplasmosis and encephalitis for our lady patient at this time? Is the answer no? She isn't at risk of toxoplasmosis and encephalitis? Or is it no? She is already protected from toxoplasmosis and encephalitis by her sulfamethoxazole trimethoprim tablets that she takes once daily? Or is it yes? She should receive azithromycin 1.2 grams orally once weekly? Or is it yes? She should receive Dapsone 50 milligrams orally once a day. So I'll give you 10 seconds to choose the correct answer. So I would settle for answer B. In my opinion, answer A is incorrect. This patient is at risk of toxoplasmosis and encephalitis because her CD4 count is below 100. However, she's already protected from this OI by the Bactrim sulfamethoxazole trimethoprim that she takes daily. And this is the preferred prophylaxis agent for this particular opportunistic infection. So additional prophylaxis is not indicated at this time on top of the Bactrim. So because of that explanation I've offered, answer B is correct and answer C is not correct. That particular choice of azithromycin is the ideal choice for MAC prophylaxis, not toxoplasmosis and encephalitis. And answer D is incorrect. Dapsone is not used alone to prevent toxoplasmosis and encephalitis. It is usually used in combination with pyrimethamine and leucovorin. So that would be the wrong choice to manage or to prophylax against this OI. Let's move to the next question. J.H.K. is a 35-year-old African-American who is HIV positive and develops hemolytic anemia while taking sulfamethoxazole trimethoprim for PJP prophylaxis. So, which alternative agent would you switch him to avoid a case of PJP pneumonia in the future? Would you settle for Dapsone 100 milligrams orally once a day? Would you switch him to 1.2 grams of azithromycin once a week taken orally? Would you switch him to 500 milligrams of levofloxacin taken orally once a day? Or would you settle for 1.5 grams of atovaquone orally once daily? I'll give you 10 seconds to choose the correct switch. So I'll settle for 1.5 grams of atovaquone once a day orally. Answer A is incorrect. This anemia suggests that the patient has G6PD deficiency. Now, Dapsone isn't appropriate because it is a sulfone and it can also cause hemolytic anemia in patients with G6PD deficiency. Now, option B is incorrect. Azithromycin isn't used for PJP prophylaxis. It's used to prophylax against MAC. Answer C is incorrect as well. Levofloxacin isn't used for PJP prophylaxis either in any form of literature. Answer D, therefore, is correct. Atovaquone 1.5 grams orally once a day is one of the best alternatives to sulfamethoxazole trimethoprim for PJP prophylaxis. So I would settle for that one from this list of 4. Let's move to the next question, which reads, P.O.K. takes the HAART regimen of Atazanavir boosted with Ritonavir plus azithromycin plus lamivudine. He also takes sulfamethoxazole trimethoprim for OI prophylaxis. Now, my question to you is, which drug in his medication profile is associated with the greatest risk of lactic acidosis and severe hepatomegaly with steatosis from the lists below? Is it the NRTIs, azithromycin and lamivudine, or is it the boosted atazanavir, or is it the sulfamethoxazole trimethoprim combination, or is it ritonavir? I'll give you 10 seconds to make the correct choice. So in my opinion, A is the correct answer. Now the NRTIs are most commonly associated with lactic acidosis and severe hepatomegaly. That makes answers B, C, and D incorrect. They are rarely associated with this side effect. Let's move to the next question, which reads, Mr. K.O.K. is a 30-year-old HIV-positive man who is experiencing dyspnea, and he goes to hospital. His viral load is undetectable and his CD4 count is 280. He's currently on boosted atazanavir alongside emtricitabine co-formulated with tenofovir disoproxil fumarate, and he takes sulfamethoxazole trimethoprim as OI prophylaxis for toxo and for PJP. Now, based on his oxygenation, we are told he's desaturating. His oxygen cells stand at 85%, and he has a slight fever of 99.2 degrees Fahrenheit. Your clinician chooses to admit him with an apparent lower respiratory tract infection. His PaO2 is 78, and he reports having brief contact with a friend who had TB of the spine, that is extrapulmonary TB. A sputum gram stain grows gram-positive cocci in pairs, that is significant, with a few epithelial cells, and K.O.K is placed in isolation, and sputum smears are to be collected each morning. So, which of these therapies should K.O.K receive empirically? Should you give him sulfamethoxazole trimethoprim at a dose of 15 to 20 milligrams per kilo per day of the trimethoprim component, either orally or IV, or should you give 1.5 grams of atovaquone taken orally once a day, or should you administer a gram of IV ceftriaxone plus half a gram of IV azithromycin, or should you administer 1.5 grams of atovaquone orally once a day plus a TB regimen of 300 milligrams of isoniazid, 1.5 grams of pyrazinamide, 1.2 grams of ethambutol, and 150 milligrams of rifabutin every 48 hours. So I'll give you 10 seconds to make the correct therapeutic choice. Personally, I would settle for C and infuse ceftriaxone at a gram and 500 milligrams of azithromycin, and I would remember to infuse the azithromycin over at least an hour, because macrolides administered IV tend to be very harsh to the blood vessels. They are prone to causing a lot of painful discomfort, and they may cause phlebitis as well. So answer A, in my opinion, is incorrect. Patients like K.O.K are at a risk of for bacterial pneumonia, and the sulfamethoxazole trimethoprim isn't good initial treatment, although it would be a reasonable option for prophylaxis of PJP. Now, B also appears incorrect to me. Atovaquone isn't the best agent for patients like K.O.K, who is at risk of a bacterial pneumonia. But option C is correct to me. The gram stains are consistent with the pneumococcal infection. So this combination of ceftriaxone and azithromycin is the best initial treatment from that list for patient K.O.K. And answer D appears incorrect. The TB regimen is inappropriate because there isn't enough information to suggest that he has active pulmonary TB. So once TB medications like the ones listed are initiated, a patient typically is committed to taking them for a total of at least 6 months. So depending on the ability to rule out TB or to finish the course of therapy, a patient risks contracting TB from a person with his risk of contracting TB from a person with extrapulmonary TB may be very low, so I would not opt for that option. Next question. OJS is an HIV positive Caucasian male patient who has been initiated on what we call the quad pill, which consists of elvitegravir boosted with cobicistat, taken alongside the co-formulated tenofovir disoproxil, fumarate, and emtricitabine. Now, this treatment began 4 weeks ago, 28 days to be specific, and today he complains of feeling very sick, and he's been sick over the last 7 days. He claims he cannot urinate. Now, the HIV consultant at your clinic thinks our patient has developed Fanconi syndrome, which is characterized by tubular proteinuria, aminoaciduria, phosphaturia, glycosuria, and bicarbonate wasting. So, which of the following is the most likely cause of this acute kidney injury? Is it HIV-associated nephropathy? Could it be the tenofovir disoproxil fumarate? Could it be the pharmacokinetic booster cobicistat? Or is it the emtricitabine? I'll give you 10 seconds to make the correct choice. So in my opinion, it is B, tenofovir disoproxil fumarate. Answer A is incorrect because HIV-AN is plausible in this patient based on some of the clinical symptoms, e.g. proteinuria. But Fanconi syndrome has a stronger relationship with TDF, which makes option B the correct one. Tenofovir disoproxil fumarate causes more incidences of this syndrome as compared to TAF, for example. And answer C is incorrect in my opinion. Cobicistat can cause increased serum creatinine because it inhibits secretion of creatinine at the tubular level, but it does not directly cause renal failure with Fanconi-like syndromes. Now, answer C therefore is incorrect, and answer D is incorrect as well. Emtricitabine does not commonly cause Fanconi syndrome. It's not recorded in literature. So let's move to the next question, where patient B.B.K reports to have been adherent to his regimen. He takes Rilpivirin, tenofovir desoproxil and Tricitabine, and he's been on this regimen for 180 days. The current viral load stands at 400 and the CD4 is 200. This regimen is switched to lamivudine and bacavir co-formulated and boosted darunavir option. Now 30 days into this treatment, when you made that switch, patient B.B.K complains of fatigue, nausea and vomiting, and he tells you he has noticed a rash on his skin. So what is the most likely cause of these symptoms? Is this iris, or is it a drug-drug interaction between bacavir and ritonavir, or is it metabolic syndrome caused by the protease inhibitor therapy, or is this hypersensitivity to bacavir? I'll give you 10 seconds to choose the correct answer. I would settle for D. This looks like bacavir hypersensitivity. Answer A is incorrect. This is unlikely to be iris. It's less likely than a hypersensitivity reaction to bacavir, since we know that he has been on HAART for more than 30 days prior to this switch. Yeah? So iris usually appears quite early in treatment. Therefore, the symptoms are not consistent with iris. Answer B is incorrect as well, because bacavir and ritonavir don't have a drug-drug interaction reported in literature. Answer C is incorrect in my opinion. Protease inhibitors such as ritonavir and darunavir can cause hyperglycemia, insulin resistance, and dyslipidemia. Now, the nature of the timing of B.B.K's symptoms are more consistent with hypersensitivity to bacavir, and that makes answer D correct. Now, the nature of the timing of the symptoms are more consistent with hypersensitivity to bacavir, and the HLA B*5701 genotype testing should actually be done to determine whether a patient is at risk or this type of sensitivity or not prior to initiating of therapy. So there was a lapse when this switch was made. So my dear listener, that brings us to the end of part 10 of our pharmacotherapy MCQ series. And I highly appreciate the fact that you, esteemed viewers and listeners, made time and sacrifice to be here to listen to and to watch this video. Now, if this video helped you in any way, I would like to urge you to remember to like it and to subscribe to my YouTube channel if you haven't yet subscribed. And I want to promise you that the best is yet to come. Thank you for viewing and for listening, and I look forward to interacting with you in the next video. I wish you high impact pharmacotherapy in your line of duty. Thank you.